Okay, good afternoon everyone. So today's my topic is prevalence and clinical correlates of orthostatic hypertension and hypotension in diabetic patients. So as we can see, orthostatic blood pressure changes are usually common in diabetes, and this is mostly related to autonomic neuropathy. Most commonly cited postural change abnormality is orthostatic hypotension, where we get a fall of systolic blood pressure of more than 20 millimeter of mercury or diastolic blood pressure of more than 10 millimeter of mercury. And we get to see this incidence of approximately 20% in the diabetic patients. What we have less seen is the orthostatic hypertension, where there is an increase in the systolic blood pressure of more than 20 at 3 minutes of standing, and there we have an incidence range of 5 to 30% because of the limited data, limited studies, which make the studies challenging. And the pathophysiological mechanism of orthostatic hypotension, we all know it is the baroreflex mechanism which is present in our body, which maintains the hemodynamic response, which on becoming abnormal there is an incidence of orthostatic hypotension. But in case of orthostatic hypertension, the mechanisms are still unclear. So the objectives of our study is to estimate the prevalence of both orthostatic hypotension and orthostatic hypertension in diabetic patients, to compare the baroreflex cardiac gain among these three groups, that is hypotension, hypertension and normotension groups in diabetic population, to assess any associations of both types of blood pressure dysregulation due to postural changes with duration of diabetes and glycated hemoglobin. So the study was conducted in BC Roy Technology Hospital in association with IIT Kharagpur, and with the sample size calculation, we recruited approximately 142 patients, and 142 diabetic patients who were diagnosed with diabetes within 4 years. So from the medical history records, we extracted the socio-demographic data. Then we estimated the hemoglobin, glycated hemoglobin, fasting plasma glucose levels. We performed the Toronto clinical scoring system to assess any presence of diabetic polyneuropathy. Then blood pressure was measured twice during the lying conditions as well as at 3 minutes of standing. Now, this is the scoring system which assesses the peripheral neuropathy, with 0 being the minimum score and 19 with the highest score. And it includes both the reflexes, symptoms and the sensory examination. Now, based on the blood pressure changes, we divided the patient diabetic groups into three groups, that is orthostatic hypotension, hypertension and orthostatic normotension. Three groups were compared with the use of ANOVA, and followed by the Tukey's post hoc analysis for the group differences. And baroreflex gain was calculated with the delta heart rate to the delta systolic blood pressure. This delta is between the supine and the standing position. So the results, we see the prevalence in case of orthostatic in diabetic patients, the orthostatic hypertension was present approximately 29.5%, 26% was orthostatic hypotension, and we got significant differences in the duration in this among these groups, with duration of diabetes, years of duration of diabetes, where we can see that in the group which is having orthostatic hypertension is having the longer duration of diabetes compared to the other groups. Also, we have seen significant differences with the HbA1c, that is glycated hemoglobin, and the TCSS score, where this is higher sides the present in orthostatic hypertension group. And we have also seen the differences in the smoking and the physically low physical activity, which was not significant while doing the post hoc analysis. So this is the result which showing the differences in the systolic blood pressure and the diastolic blood pressure changes in the diabetic group, but we are more concerned with the change in systolic blood pressure and change in heart rate. So we can see the change in heart rate was maximum in case of hypertension, orthostatic hypertension in the diabetic group. And there is a gain that is positive gain in blood pressure of 12.68 in orthostatic hypertension group. And there is a drop in blood pressure that is an orthostatic hypertension group of 21.05, which makes the baroreflex index 0.21, which is an indicative of neurogenic hypotension. This is the scatterplot relation showing the correlation with the systolic blood pressure changes and the duration of diabetes. While combining all the groups, this suggests that patients with longer duration of diabetes tend to have greater orthostatic increase in systolic blood pressure. Also, we have a positive correlation with glycated hemoglobin and the systolic blood pressure changes. As we can see, the orthostatic hypertension patients who are diabetics, they are demonstrating greater HbA1c levels with the greater BP changes, which is in accordance with previous studies that poor glycemic control is related to the diabetic autonomic neuropathy. And also, the orthostatic hypertension had diabetes for a significantly longer duration than those with orthostatic hypotension or normotension. Now, here the possible explanation for this 26% of the diabetes to be hypotensive is the postural sensitive changes because of the autonomic neuropathy. And the orthostatic hypertension is generally attributed based on few studies to the efferent pathway of the autonomic nervous system, which is mainly denoted by the overactive vasopressor system. It can also be affected with age and other conditions like chronic kidney diseases. So the limitations of the study are, we have done your active stand test. Few studies have done tilt table test, and longitudinal studies are required to reach the hypothesis. Future implications are blood pressure variability includes both orthostatic hypertension and hypotension. It is an indicator of cardiovascular morbidity. So in case of diabetes, we should move more towards a proactive prevention-centered model than reactive approach. So these are the references, and this is my the study group. Thank you.